there we go. Actually, okay.
Anyway, I'm not recording at all. Means it automatically goes from my machine. I don't know how.
No problem. I think I've hit record now, so I think it may be now recording. Okay, so in the interest of time, I'm going to hand straight over to Stuart, who's going to talk. Sorry, not Stuart. Sandip first, who's going to talk about the work that he has been doing for modeling nutritional interventions. Sandip, over to you.
Okay. Thank you, Phil. And let me share my screen first. Share screen. Can you see my screen?
Yep, we can see the whole slideshow, not the presenter. There we go. Yeah, perfect.
You got it, right? Okay. Thanks, Finn and everyone, for giving me the opportunity to present the our recent work on nutritional support, what could be the impact of nutritional support in the Southeast Asian regional countries. So in this talk, I will be focusing only on the methodology, mainly on the methodology. Result and discussion part, it is published work, so you can go through it. But as a for time constraint, we will focus on the methodology, on the modeling aspects. So this is the paper for which I will be talking about. Is in Lancet Regional Health. So this work is based on the recent study, recent trial study by Anurag Bhargava and team that came in Lancet. So I'll start from there. What evidence we got from that study, and what is applied in the model. Then I will go through the modeling approach, the model structure, and how we model it. And simply just I will brief some findings and summarize. So these are the main two papers based on which this modeling study is done. First one is published in Lancet, and the second one in Lancet Global Health. So the first study suggests that nutritional supplement in household context could reduce tuberculosis around 40 to 50%. Observation period was 2 years, follow-up period. And not only that, it also reduces, it can reduce hazard of deaths, that is 0.39, if weight gain is 5% in 2 months. So these are the most important information that has been used in the model. So now, as I said, that I will describe the model more rigorously than all other details here. So this is the model structure. This mainly a compartmental model, differential equation based compartmental model, the way we develop all the modeling for TB model. So it is divided into some compartments, like uninfected people, say in the U box or uninfected box, those people are there. Then getting exposed with the disease, they can come to the latent infection, they develop latent infection and different stages of latent infection, latent fast, latent slow, and they ultimately develop active disease, either through progression or deactivation, they develop active disease when we say that these are the disease people. Now, once they develop active disease, there is a chance of they will seek care for treatment or diagnosis, first for diagnosis. So where do they go? Either in Indian context, we can say in public sector or in private sector. So it is divided into where they are going, means either in the NTP sector or non-NTP sector. At the bottom, this is NTP sector. So now there is a chance of getting diagnosed by TB as a TB or not. If they're diagnosed, then there is a chance of going for starting treatment in this sector. And similarly, if they fail diagnosis, they can come to this box. The middle box is called misdiagnosis or temporary disengaged sector. Now these people, so in both sector, in public sector, private sector, if they diagnose properly, they can start treatment. Now those are misdiagnosed. They are not fully there. They will not stay there for lifelong. Either they will search for next provider, either in the public sector or in private sector. Finally, if they diagnosed after some rotational things, means from this way diagnosed or not diagnosed, then they can ultimately start treatment, or there are three options. Either they are self-cured or death or getting treatment. So there are three probabilities. So if they start getting treatment in these sectors, now after getting treatment, there is again chance of curing or failure or relapse, failure or default. Those things are possible. So according to, but after curing, we can say that they will be cured for lifelong. There is a risk of relapse is always with them. So we divided that into three categories: either low relapse risk or high relapse risk, or someone in the intermediate stages. So there is chance of relapse. Now, this model also considered self-cure. This model considered reinfection. Those are not shown in the diagram here. And so this is the main structure of the model. And one more important thing is the mortality, TB-induced death rate. We consider this red boxes you see, all these are infectious compartment boxes, from those are spreading the disease. We consider mortality due to TB, death rate death due to TB. Also, death is considered during treatment, that is different in public sector and private sector. Those are there in the during treatment is different than the those are not getting treatment. Is around 2 times higher in non-population. So now this model, as per requirement, as we wanted to look after the impact of nutritional support, this model has 3 layers. One is with normal BMI. Those are in normal BMI, the structure I showed here. The second stage is considered that low BMI, the population, those are in the low BMI population. According to BMI categories, there are 3 structures. So normal BMI, low BMI, and the intermediate one is that low BMI population, but those are getting nutritional support. So this is the main structure, having 12 compartment. Now, if we add up all 3, then the number of compartment will increase gradually. So anyway, what is the difference between this low BMI, normal BMI, and with nutritional support? That is important here. Now I am going to focus this component only. Though the model has all these BMI, according to BMI status, the structure is same, but we will focus this part. What is to indicate what is the difference between these nutritional BMI status. So here, see the left-hand column is showing that normal BMI structure, that are infected, then latent fast, latent slow, and active disease, and right-hand is showing the low BMI population. Now, as we did this study for all 11 CR countries, actually not 11, 10 out of 11 CR countries in this region. So according to for each country, actually the BMI level means undernutrition level is different. So accordingly, this population in low BMI and the normal BMI would be different. And what we know is that the relative risk of TB among undernourished people is about 3.2 from WHO. We got this information. So the relative risk, that means the prevalence of prevalent cases, the rate of prevalence from low BMI is 3.2 times higher than the normal BMI. Okay, this is one important information. And other difference is the effect of undernutrition is to amplify the rates which TB infected individuals progresses to active disease. That means the rate of progression and activation, say from here the parameter U and W, those are developing the active disease. This is different in low BMI population and the normal BMI population. We assume that this is, see here, W times K multiplied U times K. That means it is K times higher. We assume that this is K times, so the rate is something higher than the normal BMI population. Now we estimated this value K to fulfill the above condition. Above condition means that relative risk would be 3.2 times higher in the low BMI than the normal BMI. So we estimated the value of K. What is the value of K to fulfill that condition, that risk is 3.2 times higher. And one more thing we should mention here, that the relapse risk among low BMI is about 4 times higher than normal BMI. Here it is indicated that relapse here and this one, the right hand column, is 4 times higher than the normal BMI. This is the basic difference between normal BMI population and low BMI population. Now it comes to the intervention scenario. The structure is same. Now here those are getting nutritional support. Now from low BMI we are giving as per interventions we will give nutritional support to these people. So if they get nutritional support, they are coming here. But the difference between these two, low BMI and low BMI with nutritional support, is that again the activation rate and progression rate would be different. So here K becomes K prime. You see, U K prime and W K prime. Consider this. And it is assumed that, okay, after getting nutritional support, they will have the same relapse rates as normal BMI. And this K, now the activation rate and progression rate has reduced. So what fraction means? So what should be the value of K prime? That we estimated from the RATION trial study. So we know the incidence cases reduced by 40% among these people if we intervene them. So from that condition, we find out the value of K prime. What could be the value of K prime to give that incidence reduction to be 40%, as we observed in the recent trial. So this is the main structure for this analysis. Now there are assumptions. What are the main assumptions is that activation and progression rate is higher among low BMI. This is the major thing. Second is the relapse rate is 4 times higher among low BMI relative to normal BMI. TB-induced mortality among low BMI is twice high as normal BMI relative to normal BMI. And case fatality during treatment is around 4% for normal BMI, whereas for low BMI it is 6% during treatment. And we ignored any nutritional shocks related to COVID-related pandemic. Mostly all these informations are available from literature, and considered for all 11 countries is the same. This is another assumption. I mean, it is not that this will vary from country to country. The assumption is simple assumption is that all country has the similar features. We get some information, say for case fatality treatment, we get this information from India studies, and we use it for all other 11 countries, 10 countries. So with nutritional support, the effect of nutritional support, as I said, that infection cumulative incidence reduces by 40% to lowering the progression and reactivation rate. We assume that restore mortality and relapse hazard will be the same as the normal BMI. And case fatality rate during treatment at the same level as normal BMI with nutritional support. Now, those are the model structure. Now, interventions. These two, now for our purpose, so we consider that two types of interventions. One is if we target only the household contacts and put them in nutritional support among all contacts, regardless of nutritional status, whether they are in low BMI or normal BMI, just give them nutritional support to all household contacts. And what could be the impact? We observe that. And secondly, we observed another scenario. We develop another scenario where nutritional support is given to 30% of undernourished people each year. All low BMI population will get 30% nutritional support. Now these are modeled into the way already I explained that from transferring the people from low BMI to low BMI with nutritional support, that the middle column, shifting them. And this is done. It is not that immediately after putting them in the next compartment, we scaled up the interventions in 3 years, means starting from 2023 to 25. It is linearly scaled up to achieve that target level.
Sandip, just to interrupt you for a second, say we've got about a minute left if we want to keep 15.
Yeah. These are the last slide. I think 2 more slides I have. Only the results. Thank you. So for this is the result for if we look after that status quo comparator, means without any other interventions, only we see the impact of nutritional support. And the right hand column shows that if we see that nutritional impact of nutritional support along with the other interventions. Bottom column shows the death projection, and how it varies. The number varies from country to country. The impact varies from country to country. For India, it is say 24% for incidence reductions, whereas in status quo scenario, mortality 35%, whereas in Bhutan, it is lesser because the because of nutrition status. So we observed also the cumulative reduction by nutritional support. Without nutritional support, this is the impact with improved cascade scenario, and with nutritional support, the red part comes. Similarly, we assume first one is for household context, just intervening household context. Now this one is if we intervene 30% of the low BMI population, what could be the impact? So already there is no need to, I think the summary is already, I mentioned that what will be the impact in different scenarios. So of course, if we intervene 30%, the impact would be higher, and it varies from country to country. Yeah, I would like to thank for this work we did with CRO. So with Vinit Bhatia, I would like to thank with Vinit Bhatia, Anurag Agarwal, Suman Rajai, and Neem Pathi from WHO. So thank you all.
Brilliant. Thank you so much, Sandip. Any quick clarification questions from anyone before we move on to Rebecca, and then more discussion at the end? I don't see any hands. Putting a couple of questions. Yeah, apologies. I know that it's a lot to cover in a short space of time. I'm just having a check to see if these are clarificational for discussion at the end. I think your first question is probably more of a discussion point. How much of the overall intervention impact for feeding whole countries could be captured by just feeding families and contacts? I think that probably is maybe, Sandip, just a quick comment on that, because it's around how the assumption of your intervention, how you link
Can you repeat the question? Means what would be the impact of at least household context, right?
Was how much of the overall intervention impact for feeding whole countries could be captured by just feeding families and contacts? But I think that's, well, there's two elements there. It's partly how do you probably get from rations to your assumptions about the whole country, but then also backwards, how much, yeah, including that as well. Sorry.
So in the ration trial, they targeted only the household context. Low BMI, the state they have studied is Jharkhand. The status of that country is, of course, not rich country, is kind of a poor country, but the impact depends on what is the nutritional status, overall nutritional status in that state, right? Means then the study domain was in the household context without looking at that nutritional status. It is not that only low BMI population gets the supplement. They give the food supply to all household contacts, regardless of nutritional status. So that's why we use that.
Sorry, let me clarify my question. I apologize if it wasn't clear. Putting here. Thanks for the presentation. Just wanted to try to understand, you had an overall effect estimate of reduction on incidence of mortality with this whole population feeding over a few years of undernourished populations in the larger intervention. And then you showed a reduction among contacts. So what I'm getting at is that how much of the overall incidence of mortality benefit of the overall pan feeding intervention was across the range of countries? You know, what was the sort of relative reduction in impact on the overall epidemic when you limited the intervention to just the household, TB affected households? In other words,
that would be very less actually. The impact would be very lesser than if we don't target the whole population, say 30% population. But if we target only the household contacts, the impact would be very less than 5% for almost all the countries.
And that was true across all the countries, I guess is what I'm getting at, because that's the new data that we're seeing here.
that varies from country to country. It is not that for each country it is the same. Depending on their what is the status, nutritional status in that country, what is the say how the ppm interventions means, how you are getting that. This is only the if you give the ppm interventions, then automatically the notification will increase. So number of getting food supply, number of getting the supplement, food supplement will be much higher. So depends on that intervention as well. It is not that only. Yeah.
Thank you, Sandip. I was just going to say, I think that's quite helpful and does clarify that. I just wanted to move on to Rebecca because I'm very conscious of time. But Rowan, I see you've got your hand raised. Do you want to add a comment in the chat for Sandip to answer there, if that's all right?
Sure.
That would be it.
Rebecca, over to you.
Thank you. Yeah, thank you very much for having me here to present. Hopefully everyone can hear me and see the slides and everything, but let me know if anything goes wrong. And so thank you to Sandip really for setting up, I guess, describing all of the different characteristics about the intervention and results from that, because that really does help feed into what I'll be talking about today, which is the work that we've done estimating the epi and economic impact of scaling up a nutritional intervention for TB affected households across India specifically. So as we heard, there was the RATIONS trial, which occurred in a specific region within India. And one of the things that we wanted to do was to assess the impact of introducing this this intervention to TB affected households across India. So we know that undernutrition is associated with an increased risk of disease, as well as associated with poor treatment outcomes compared to normal BMI. And so what we wanted to do was to use mathematical modeling. And what we used was a previously calibrated described mathematical model for introducing vaccines in India. And we extended this to include similar BMI categories. So we had a severely underweight, mild undernutrition, normal BMI, and overweight and obese categories. And we used this alongside a number of other pieces of data to be able to have the to represent the BMI distribution, as well as the increased risks of progression and disease. So in terms of the underlying BMI distribution, we had this data come from the Global Health Observatory, as well as the DHS surveys in India. And then we had BMI projections from Alexander et al. For our increased risk of disease, this was from the Lonroth et al. Paper, as well as from Sina et al., who was able to provide differences in terms of treatment outcomes. And then, of course, we had the intervention, so the RATIONS trial results, which were from the Bhargavas, which Sandip has talked us through. And essentially what we wanted to do was we broke these up into the differences in the effect on the patient outcomes, so if RATIONS was delivered to the TB patient, as well as the effect on household contacts. So what would be the effect by both either separately delivering the intervention to patients or to mechanisms, which were, and then in terms of the effect that this would have on household contacts, we looked at a reduced incidence rate ratio, as well as increased BMI in household contacts. In terms of how we introduced this intervention, so we looked at introducing it to adults on TB treatment, and we varied the intervention coverage across India. So scenarios with either 20, 50, or 80% coverage of adults on treatment. We assumed that there was instant scale up and that we were able to cover both the public and private sector with that percent coverage. While the trial measured the outcomes after around 2 years, we varied the duration of protection of the effect of RATIONS, either only on treatment, 2 years, 5 years, and lifelong. But we've also ignored this case finding component, where we would assume that there would be more in household contacts of of TB patients, and therefore we may have estimated some of the effects of this intervention. In terms of what we looked at, so we estimated the impact for 2023 to 2035 in terms of the cumulative number of TB disease deaths, DALYs averted, as well as TB costs, which were discounted at 3% per year as per guidelines. And we looked at this for the patients only, so intervention where we just saw the effect for the patients compared to introducing it to the entire household. So this was for the patients and the household contacts. And then we also looked from the health system as well as a societal perspective, so including those indirect and non-medical costs. Feedback.
Can I check, is anybody else struggling with Rebecca's connection, or is that just me?
I am too.
Yeah, I think we all are.
Okay, Rebecca, can you hear us at all?
I can hear you. I don't know what to do, guys.
Rebecca, you might go off camera to save bandwidth.
I'm not sure if we've actually lost Rebecca entirely because I can't see her. She has sent me her slide, so I can. Do you want to maybe do your presentation, and then if we don't get Rebecca back, then she sent me her slides, and I'm happy to present the rest of it. Actually, sorry, Rebecca, you are still there.
Sorry, I am here. Yeah, but sorry, it just cut out for a second. I will try to find a different connect to a different Wi-Fi. Sorry about that.
Why don't I share the slides that you sent me, and then
Okay.
you don't have to share slides at least. Right. There we go. Rebecca, can you see those?
I can see them now. Yes. Am
Brilliant.
I audible?
Yes, we can hear you now. Yeah.
For now, okay. So yeah, I think last thing on this slide was just to say that we're ignoring any post-TB or non-TB benefits of increased BMI. Slide. Okay, so moving into the results. So here we're looking at the impact in terms of cumulative TB disease prevented and cumulative TB deaths averted for the 50% coverage scenario, looking at all effects, so both to the patients and to the household contacts. We can see that between 2023 and 2035, this could avert up to 2.5% of TB disease across the country, as well as about 5% of cumulative TB deaths. Next slide, please. And then we broke this up into what would be the contribution from the different portions. So whether this was from the contacts or the patients, and what we could see in terms of averting disease is that really we're seeing a lot of the reduction in disease coming from reducing disease in household contacts. Next slide, please. And then in terms of the cumulative TB deaths averted, we can see that this is mainly broken up in quite evenly of reducing disease in contacts, as well as actually preventing those deaths in patients. Next slide, please. Just showing the results for looking at the 20% and 80% coverage scenarios. Essentially, we can see that the results scale around linearly with coverage, and we can see that the increases in the disease prevented was around 3.5% with the 80%, and about 7.5% in terms of deaths averted. Next slide, please. And just to say that this is equivalent to averting around 356,000 to 1.4 million cases and 146 to 571,000 deaths. Next slide, please. So here we're actually looking at essentially how many households do we need to deliver rations to in order to prevent one case of disease and one death. And so what we found was that in order to prevent one person developing disease, rations would be delivered to 10 households, and to prevent one person dying as a result, this would require rations delivered to 24 households. Next slide, please. That's just saying the results. Again, so then we look, those were essentially our more of our health outcomes. Looking now at the economic outcomes. Here we're looking at the incremental costs against the incremental DALYs averted. On the left-hand side, we have the scenario where patients received rations compared to no intervention. And then on the right, we have the full household receiving rations compared to only patients receiving rations. And then we can see our cost thresholds on the indicated there with the lines. We have the 1 times GDP per capita and the 2 country-specific upper and lower bounds. And what we can see here, next slide, please, is that introducing rations for TB patients is cost-effective at most willingness to pay thresholds, with an incremental cost-effectiveness ratio of $139 per DALY averted. And similarly, for the household receiving rations compared to only patients, next slide, please. Is also cost-effective at most willingness to pay thresholds, with a cost-effectiveness ratio of $208 per DALY averted. Next slide, please. And just to say, we noticed qualitatively similar results from the societal perspective for the different varying coverages, as well as for varying duration of protection. Next slide. So here we're just looking at breaking down the costs that would be associated with introducing this intervention. Again, on the left to people on treatment, and on the right to people on treatment and their household contacts. And these are both compared to no intervention. So we have the intervention costs on the top and the diagnostic and treatment cost savings at the bottom. And these would be compared to the total cumulative cost of no intervention for the entire period of around 8.6 billion. Next slide, please. We can see that the total cumulative cost for introducing rations delivered just to people on TB treatment was around 663 million, which was broken down into the intervention cost of 683 million, and then diagnostic and treatment cost savings. Next slide, please. For the rations delivered to people on TB treatment and their household contacts, there was a total cumulative cost of around 1.3 billion, with the intervention cost being 1.5 billion and diagnostic and treatment cost savings. Next slide. Overall, nutritional support can significantly reduce the TB burden in India, but we found that the effect size was constrained. We only introduced this intervention to households and to people who are receiving TB treatment, and therefore we were constrained by the diagnostic rate and the rate of starting treatment. We found that it was likely cost-effective at most willingness to pay thresholds, and actually we believe that as we're undervaluing the non-TB benefits and post-TB, the actual impact from introducing these intervention is likely greater. Next slide. And just to say thank you to everyone who had contributed, the TB modelers at the London School, and to TB epidemiologists and economists, so Anurag, Madhavi, Bhargava, and Pranay Sinha, as well as the food systems modelers, Peter and Roslyn. And thank you very much for listening. I'm very sorry about any of the connection issues, but hopefully you managed to hear mostly the presentation, and thank you very much for listening.
Thanks, Rebecca. I think it was much clearer after I started showing the slide, I believe. Do we want to take, for 1 minute, any quick clarification questions, and otherwise we can have questions for later? All right. If there's no clarification questions, then I will pass on to Stuart, and hopefully we should still have a little bit of time at the end for discussion as well. Thank you.
Great. Thanks, Sven. Let me just make sure that you all can see my slides.
Yep, we can see them.
Great. Yeah, so thanks so much to Sandip and Rebecca for those great talks. I want to talk about some of the modeling that we're doing at the Institute for Disease Modeling within the Gates Foundation to help address some questions that we've seen being relevant from the RATIONS study. So in the short time, I'm going to just touch on three questions that we've been looking at and just phrase them here. One, how might undernutrition impact other new TB tools that we're developing, such as new diagnostics or vaccines? Two, also, how might nutritional rehabilitation affect TB burden? Sort of the same question that Sandip was talking about. And finally, I want to touch on new work that we're doing to examine the role of macro and micronutrients in TB control. So just by way of background, I just want to pose something that we've noticed in the literature, and I think these are papers that we've been talking a lot about today, but just to kind of make sure that everyone's on the same page about this, there's this classic paper from the Lonroth 2010 study about the effect of BMI on TB incidence, but on the right is the RATIONS result. And what I want to point out from the RATIONS result is that actually, I think Sandip mentioned this, that the weight gain and the change in BMI was actually relatively marginal, and the intervention was only given for 6 months. And so, there's still a lot, I think, that we don't understand about how BMI and how undernutrition works to affect TB risk. And I think there's, regardless of kind of the projections that we do right now, there's still a lot just about the underlying science that we don't understand. I want to talk about the three questions: how might undernutrition impact new TB tools, and just mention how we've actualized this in our own TB model. So we have a model that's has these states, but is operationalized as an agent-based model. And what we started to do was start to play with this and say, well, if we start from our homogeneous model assumptions and then add in undernutrition as a risk group, and then recalibrate the model, and then implement new tools like diagnostics and vaccines across the different models, does this affect, does that addition of risk groups change how the impact looks for these different new tools? Just showing how we've implemented those assumptions as like a undernourished group having the same risk, or 2 times the progression risk, or 3 times the progression risk, consistent with what's in the Lonroth paper. And then with these 3 different models, if you will, we've then calibrated based on base infectivity to the India data, and just tried to make sure that we have about the same quality of calibration to reproduce trends in incidence as well as prevalence and mortality. And what you see is that depending on the assumptions that we've implemented, then the undernourished represent different proportions of the overall burden from 10 to 30, from 20 to 30 to 40% of the population burden. And one interesting thing that we've noticed is that depending on this set of assumptions, depending on whether your population has homogeneous risk or has heterogeneous risk, that actually has a big effect on then other things that you want to do with the model. For instance, if we try implementing a M72-like vaccine at a high rate of coverage, you can see that if we have a homogeneous model, that we have a relatively robust impact predicted within 10 years. But then as we have a more heterogeneous model, then that impact starts getting whittled down. So, I think this is really just a cautionary tale for us as modelers, that depending on how we represent undernutrition, that will have knock-on effects on other things that we want to do with the models. And just a word on kind of the theory behind this. There's this great perspective piece that I've linked here, the Trower 2019 paper that has a lot of the TB modeling community on it, that highlights this issue. So, as you have more heterogeneity in your models, that changes the dynamics of your models, has an effect on R naught and other control interventions that you do on top of that. And I think the figure in the lower right, which is from Gabriela Gomez, illustrates this pretty well for here a vaccine that's implemented as you have increasing risk heterogeneity, whether it's from nutrition or whether it's from hotspots or something else. You see that apparent impacts start to go down, especially in high incidence settings. And I think this might also explain why TB projections were rather optimistic in how they thought DOTS was going to perform in the 1990s, and some countries that had a lot of heterogeneity did not see those actualized. So yeah, maybe just a side note here, that is not just nutrition related, but I think we really need to examine risk factors and interventions in the same model. I want to also just touch on nutritional rehabilitation. So this is the same basic question that Sandip was looking at. And I've taken the three models that I've shown you and then try to represent what happens if we rehabilitate a large proportion of the population. I won't go into like the scenarios and the assumptions here for time, but just to mention that we get similar kind of projections that rehabilitating in India setting would reduce TB burden by a significant proportion. And just for kind of my own curiosity and to help kind of inform or kind of set the context for these results in the foundation, I wanted to do a quick kind of back of the envelope meta-analysis, if you will, compared to other models that were published, including Sandip's, but also this O'Done 2014 paper and this Oxlade 2015 paper, which all examined India at different scales. And what I want to point out here is, in blue, I've shown on the X, what happens as I've aggregated these results from different models. On the X-axis, you have the proportion of the undernourished population and what happens as you reduce that by year in these different models. And on the Y-axis is the relative incidence reduction at each of those years compared to baseline. And so I think there's a lot of commonalities here because we're all using the same basic assumptions from the Lonroth paper, basically, and maybe also the RATIONS paper to indicate that you have a 2 or 3x reduction in risk. But I think highlighting that there's still a lot of unknowns. I mentioned that the RATIONS paper actually observed a pretty small change in BMI, and we see that reflected in the small difference in the undernourished BMI less than 18.5 proportion of the study arms. And so I think the difference in the red and the blue and the orange curves just tells you that there's still a lot that we don't understand. And I know we're quite short on time, so I just want to touch on one other thing, and that is that we're starting to look more at kind of the science and try to pick out what is going on in this the RATIONS intervention and other macro and micronutrient interventions. They're complex interventions. We know a lot is going on at the biological level. There are interactions between macronutrients and micronutrients to determine TB risk that are not captured by BMI. We know that when you give food to households, you're also stepping into a lot of sort of interesting social dynamics. So household dynamics, ideas about substitution, as far as if families are actually changing how their household budgets work. We know that there's a lot going on with the different components of these interventions. So all of these things that I've listed here and more have been speculated to have an effect on TB natural history. So proteins, lipids, vitamin A, niacin, vitamin D, other things. If you want to look at the literature for any given micronutrient and TB risk, there's a good chance that somebody's tried studying it in the lab and seen some kind of effect. And then finally, there's a lot that we don't understand about the dynamics. So BMI is sort of a record of the cumulative macronutrient and micronutrient status, perhaps. but that might be having a different effect than just your recent macro and micronutrients, which may be acting differently biologically and may be having an effect on different parts of the pathway. So I just want to just mention some recent work that we're doing on this, and we're trying to fit now trial data to these different hypotheses using a new kind of model and see if there's ways that that'll point to optimizing these nutritional interventions. And so I just want to mention this really cool study that we started looking at in the 1940s in New York. There was actually a trial of micronutrients alone that was done over 5 years in a relatively small number of households, and with just 2 arms in these household contact families. And what they did was gave a therapeutic dose of micronutrients in the first year, and then scaled it back to a maintenance dose of micronutrients. They also observed what happens as you counsel these families in both groups, and there are definitely a lot of changes going on in the 40s with the war and other things to see how did their food habits change. But then, what they observed was that the sort of edge of significance results that people who, or families that had micronutrients given to them actually observed a quite dramatic difference in their subsequent household incidence. So, the results are not significant, but they're just on the edge, and definitely very interesting to think about. And so we started to just ask some what if questions with our another model that we started developing just to look at hypothesis exploration. And just to show you like sort of the questions I think that we need to address as a field. So what happens as food habits change within households? And so we looked at the data from that study between 42 and 44, and there was definitely a change in overall food habits and patterns. And we speculate that has, that's a marker of their macronutrient status, but it's also changing their micronutrient status as well. And then that's going to differ between the treatment and intervention arms. And on the right, I show how we're then trying to map this into our model and say that, well, maybe if you have micronutrients at a sufficient level, you have a protective effect, and so your TB progression rate is lower. But then if you have a poor micronutrient status, then that maybe is when your low macronutrient status might have an effect and kicks in, and then your TB progression rate might actually go up. And so I don't want to show any results from this today. It's still very much work in progress, but I just want to sort of point to and maybe stimulate discussion on, well, what other things do we still have to learn from RATIONS, from the Harlem trial, from other data that are out there to tell us how, what other sort of studies do we need? Where should the field be going after this? So just to summarize, I know I flew through a lot of concepts quickly here, but those same 3 questions, we saw that in our models, accounting for risk heterogeneity from undernutrition reduces the impact of new TB tools by quite a significant amount. So it's something that I think that we should all pay attention to, all of us modelers who are looking at nutrition and risk, but also, looking at M72 or new TB diagnostics. Second question about nutritional rehabilitation. We also observed, like Sandip's model, that eliminating undernutrition reduced TB incidence by quite a large amount in India and perhaps other places as well. And then just wanted to mention kind of this ongoing work that we're doing to identify what is it about nutrition? Is it the macro or micronutrients? What is the actual mechanism that results in preventing TB? So I end there and just to acknowledge the work of my colleagues on this. Many of us at the Institute for Disease Modeling chipped into this, and I definitely appreciated the interactions with the Bhargavas on this and with with you guys on this call too, Finn and Sandip and Rebecca and others. So I'll pause there and take any questions. Thank you.
Fantastic. Thank you, Stuart. Yeah, so maybe before we open for sort of more general questions, any specific clarification questions for Stuart? I think that last part in particular, I'm struggling to get my head around. I think it's a really interesting piece that, yeah, I'll be interested to see where you go with that. Okay, so we have 5-6 minutes left for more general sort of discussions and questions to all of the speakers. I haven't actually kept track of the questions in the chat very well because I was trying to listen to Stuart. But did anything come up there, Puneet, in particular? Were your questions answered there? And if not, do you have any further questions? And does anybody else have any further questions? I think maybe while we wait for that, Stuart, one thing which you've shown me before, and I'm still can't completely get my head around, is that plot where you've plotted all the different studies. I'd be really interested if you could show us that again and maybe take me through it more slowly, because I've definitely not quite grasped it fully yet. And I think that's a really helpful one to show how we have how these different models are predicting and how that compares to data. The bit that I particularly have struggled with here is trying to understand how the RATIONS trial fits into that. What that means, for example, when you have the proportion of undernourished population and control in the intervention, is that just saying in the control arm before the intervention there was just less than 30% undernourished population in the RATIONS trial, and then in the intervention arm it was a bit more, and that's pre-intervention.
Yeah, I indicated here in the notes what that the Bhargava trial difference actually was. Yeah, they observed, I think, we're all well aware that the Jharkhand state setting is quite impoverished. And so 38% of the cohort had BMI less than 18.5. And then with the intervention, that reduced to 28% in the intervention group receiving food baskets. But the control group also saw a reduction in their undernourished population to 31%. And so it's quite interesting that BMI less than 18.5 got reduced in both arms as well. And so, that's what I'm trying to highlight here. The red curve is that you can have a small difference in BMI in both arms, but then still see like a big effect in incidence. So yeah, there's something about that sort of defies the normal expectation.
Yeah. And I don't know, Rebecca, if you have had a chance to look at this and think about because I think that's your modeling results are not on the slide. And I'm just thinking, do they look, as I would imagine, they look relatively similar to the EMOD and Mandal, and is it the Adoni one all on the right? But I don't know if do you look at that and think, do you know any of the numbers off the top of your head to know where they would fit there?
Sorry, yeah, no, not off the top of my head, but definitely it would be good to look and see where the results from that fit in.
Yeah. Okay.
Yeah, and I just want to mention quickly that this slide, Sandip does a good job mentioning like 2015 versus 2030 changes, but I'm actually looking at year-to-year changes of intervention compared to the baseline. So it's a little bit different of a metric than the one that Sandip reported. I just read them off of his curves directly.
Okay, nice. I think it's a really helpful way for us to see how do these different results compare, and are they telling us the same thing or are they not? And a lot of the modeling results are telling us the same thing. It looks a bit different to what we might expect from the trial. But then I think that, very different populations there. Any other questions? We've actually only got a minute left. Any questions or thoughts? And also, I know a lot of this happened very quickly. Sandip's paper, as you saw at the beginning of his slides, is publicly available. I know Rebecca's paper is on the verge of submission, so hopefully should be available soon in preprint and potentially published soon. Stuart, I don't know if you have plans to publish any of this, or if it's all for internal consumption, it won't necessarily be published.
Yeah, I mean, we also have plans to publish, but I think with a longer time frame than what you guys are thinking about.
Yeah, but so I'm sure Stuart, Sandip, Rebecca will all be very happy to take questions if they occur to you later, if you want to find out more or look at the paper and are still struggling with some of the concepts involved. All right, then. I think it is on the hour now. So if no one has a last question, then that's probably a really good place to wrap up. And thank you very much, all three of you. I think are really, really interesting pieces. I'm very biased, obviously, but I think they're very interesting pieces and really helpful to think about the wider context of the rations intervention. Thank you very much. And there is, just to say, there is another TB Mac talk coming in July. And I'll have to go away and check. I think it should be advertised. May, or in fact, no, it's already been advertised, but it's coming up towards the end of July, if you're interested. Thank you all for joining us.
Thanks so much.
Thank you. Thank you.